Vanderbilt University Medical Center in Nashville, Tennessee, where I also serve as the Director of Interventional Cardiology Research. And today I'll be presenting on integrating AI with traditional intravascular ultrasound coronary imaging. We were chatting a little bit just before this, and we were discussing the percentages of intravascular imaging use. And it sounds like, both in the Gulf area and Saudi Arabia, maybe in that 15 to 20% range. In some areas of the United States, we're approaching 30%, and maybe in some areas where there's sort of incentivization in terms of quality metrics, it may be increasing slightly. But certainly there's a lot additionally that we can learn from the field. And here are my disclosures. The objectives to talk about today, I wanted to quickly review the society guidelines regarding intravascular imaging use, review some differences and similarities between different imaging modalities such as IVUS or intravascular ultrasound and OCT or optical coherence tomography, review pre-stent and post-stent IVUS workflow, as my talk in particular is more focused on IVUS, whereas my colleague, Dr. Evan Schlafmitz, will be discussing more on the OCT side of things, and then provide some examples of how artificial intelligence is integrated into IVUS software using, most of my examples come from the software that I have available to me at Vanderbilt University Medical Center. And as I think we talk about this a little bit, I think it may become apparent to you that you may have been using AI and didn't even really maybe realize it, or I think it kind of, I wanted to emphasize some of the aspects of the softwares and technologies that that maybe are available to you, but we maybe underutilize. And then just to go over a few studies where AI was compared to human interpretation in recent publications, and then we'll have some additional time for discussion. So using some of the US and European guidelines as examples, I wanted to mention that at least in the US right now, we have a couple of different guidelines that speak to intravascular imaging use. On the left-hand side, upper left-hand side there, we see the 2021 American College of Cardiology, American Heart Association, and the Society for Cardiovascular Angiography and Interventions guideline for coronary artery revascularization, in which this was intended to supplant all of the prior revascularization guidelines that came before that, including the STEMI and STEMI, ACS, and chronic coronary syndrome guidelines. And in this more recent guideline from 2021, we had a 2A recommendation that IVUS could be potentially useful for cases of left main or complex coronary artery disease to reduce the risk of ischemic events, with IVUS being a reasonable alternative to IVUS with a 2A recommendation, and that with stent failure, that would be reasonable also to determine the mechanism of stent failure. So many of us, I think, were a little disappointed that this only got a 2A recommendation and not a stronger recommendation. But I did want to point out that in our more recent 2025 guidelines for the management of patients with acute coronary syndromes, this was sort of upgraded to a 1A recommendation for patients with ACS undergoing stent implantation of the left main or in complex lesions, that IVUS or OCT is recommended for procedural guidance to reduce ischemic events. And the reason why this only really comments on patients with ACS is that that was a ACS-centric guideline, so it really did not have the scope to cover patients with chronic coronary disease. But I do think that with the information that we have now, that if we did get an update sometime in the near future, hopefully that would be upgraded also for patients with chronic coronary artery disease. And the 2024 European Society of Cardiology guidelines for the management of chronic coronary syndromes does provide a 1A recommendation for using IVUS or OCT for anatomically complex lesions, in particular for left main, true bifurcations, and long lesions. I think that one thing I want to point out about this is that it's interesting that we are selecting the use of IVUS or OCT for complex lesions But I do think that sometimes we don't actually realize that we have a complex lesion until we use IVUS or OCT to define the lesion better, because sometimes we have calcifications that are more extensive than what we would have appreciated angiographically, or the lesion may be longer, or we may, appreciate more bifurcation disease. So I do think this is a little bit tricky. I have sort of tended towards using intravascular imaging towards all of my coronary lesions, unless, there might be some occasional exceptions. But I think that we probably have more complex coronary artery disease sometimes than we realize until we end up using intravascular imaging. So we'll be talking today a little bit about both IVUS and OCT. So I wanted to make a general comment that, as you can appreciate from the guidelines we just reviewed, that these are considered to be pretty much interchangeable. This is supported by the Octavus study, which was a prospective multi-center open label trial that included over 2,000 patients with significant coronary artery lesions that were randomized 1-to-1 to either undergo OCT guided or IVUS guided PCI. And so in this particular study, the primary endpoint was target vessel failure with the combination of cardiac death, target vessel myocardial infarction, or target vessel revascularization being the combined endpoint. And in this study, they looked to see if OCT was non-inferior to IVUS, and that endpoint was met in that we can interpret them as being interchangeable, and that OCT is non-inferior to IVUS based off of the findings from this study. There was a very slight increased use of contrast with OCT, but there was no resultant increase in contrast-induced nephropathy. So in general, thinking about IVUS versus OCT, they each have some advantages and disadvantages, with IVUS being obviously an ultrasound-based technology that has a little bit greater tissue penetration, does not require any additional contrast, and may be preferred for aortoosteal lesions, which might not be well visualized by OCT. With AI, I wanted to make some general comments about that. We get some very good information about vessel measurement in terms of the lumen diameter and the vessel diameter, as well as information about the stent expansion, apposition, and dissection. Whereas with OCT, we have an infrared light-based technology with higher spatial resolution. It's better for detecting plaque rupture and thrombus. Does require contrast unless you are using sort of a dilute contrast or other solutions such as saline or dextran. Challenging to clear the blood in the setting of aortoosteal lesions where IVUS may be preferred. And we do potentially get a little bit more information about plaque characteristics from OCT, and perhaps the AI is more developed in terms of identifying stent expansion, apposition, and dissection. So launching into the IVUS, sort of where we use AI versus where we would be kind of using our human interpretation. And I guess one piece of good news is that we are still needed as humans to interpret both the clinical scenario for the patient in terms of, where we should be selecting our stent location for implantation and the length of the stent, as well as some other guidance. And I don't think that we are really to the point where we can completely rely on AI for interpreting how we perform our interventions, and are still kind of at the point for using it as a tool to support our work, which is good because that's at least we have some job security for now. So the first step in IVUS is just defining the lesion length and defining landing zones. Ultimately, I do think that this is a step where we are really still using our human tools, our thought process, and determining where we want our stent landing zones to be, and identifying zones where there's not very much plaque burden, ideally less than 40% by IVUS. Then we're going to be assessing plaque morphology. Again, with IVUS, this is more of a human interpretation, looking for areas of calcification, whether it's eccentric or concentric. And then where IVUS is really helpful with the AI technology is measuring the vessel size there in number 3. So As far as the other types of post-stent workflow where we may be using AI versus our human interpretation, number one, looking for geographic miss, which we might interpret as being, if there's more than 40 to 50% plaque burden in the area where the stent edge is, that might be considered to be a geographic miss, depending on the sort of plaque burden overall in a vessel. And then again, looking for edge dissection, as you see here in that panel 1B. Checking for malapposition, so we want the stent to be fully opposed to the wall with the stent struts sort of not hanging in space, and that might be something we may be looking for manually with IVUS for the most part, and then looking for optimal stent expansion. And I will talk to you a little bit how we can use AI to identify where we may have some stent under expansion in the coming example up here. So this is a sort of a cross-section through a vessel, looking at it with high definition IVUS. We have some different tools that we can use to sort of scroll down the blood vessel. You see that sort of white little, looks like almost like a tablet. We call that a scrubber, that you can pull down the vessel and look at different cross-sectional areas. And in this particular software example, we have these arrows that point either direction, and those can be dragged one way or another to define where our lesion length would be. And then we use that as our tool for identifying the stent length as well as the plaque morphology in that particular area. So in this example, we have a relatively short length of 10 millimeters. You can see that here we're trying to establish the lesion length. And you can see on the upper right-hand corner, we have some information that has been identified by AI. So we have at the 1.44 millimeter squared area of the lumen in yellow. And then in sort of like the teal color, we have the area of 2.36 millimeters squared. That's supposed to be representative of the vessel area. Although, depending on where you select, you do have to kind of look at it and use your own human interpretation to determine if that's representative of the surrounding areas, if that should be your reference area, or if you want to sort of pull your edges one way or another. So in this particular circumstance, where we have AI assisting us is by identifying the lumen area as well as the vessel area. And then you can see here that the minimum area where it says min in the middle of those two brackets, it has identified the minimal area by AI in terms of the lesion at the most minimal lumen area. So once you've identified your healthy landing zones, you want to keep the brackets where they are. That would be keeping those fixed to determine your lesion length. And in this particular software, we have this toggle button in the right-hand side. You can actually remove the cross-sectional lumen area and vessel area if you want to be able to sort of see your plaque morphology a little bit better. And then as far as the plaque morphology here, in this particular example, this is not a very calcified lesion at the minimal area, so potentially indicating to you that you may not need any particular calcium modification tools. And so, yeah, so this on the right-hand side, it still gives you the ongoing, lumen area and vessel area. So then as far as your post-stent technology, again, probably most of you have used some of these tools, but this is where I think that maybe there might be some things you learn here in terms of how we can use the AI technology to identify the degree of stent under expansion and those kinds of things. So here we have already stented. We have a stent length of 33 millimeters. Where the ALA button is on the lower part right there, if one was to click on that, that would tell us the minimal area of the stented segment, and that would help us identify if there was any area of under expansion. And so we do want to keep this brackets fixed at this step, because that's going to be our sort of planting our marker of where the stent edges are, and then we can use those edges to do dynamic reviews at the edges to look for things like dissection at the stent edge. So, so in this particular example, you could identify here at the edge if there's any issues with apposition, geographical miss identified by the plaque burden more than 40 to 50%, and any edge dissection. You can see on the right-hand side there where it says plaque is 35%, so that wherever you have that, your marker, that will tell you your plaque burden. So a plaque burden of 35%, depending on how much other plaque is in the blood vessel, would be considered to be acceptable for the distal stent edge. I mean, obviously, the less the better, but if it's less than 40%, that's would be considered acceptable. And then as far as the stent expansion, as I mentioned, so there's some steps that you can use using the AI tools in this particular software, where you would put your scrubber at the distal stent edge to locate the distal reference. And then once you have that there, you can bookmark that location. And then you would click the reference button in the lower left-hand side. And then this will provide a reference for which you can then sort of scroll through your stented area to determine the not only the percent of plaque, you would be able to see that, but you can also determine the degree of stenosis relative to wherever you have planted your bookmark. So in this example, if you were to just pull it, a little bit off to the side, you would get a stenosis. You can see there on the right-hand side, stenosis of -1%. Depending on where you pull this or where you also put your bookmark, you can determine the degree of stent under expansion. So if you were to select a location at the very sort of more proximal end of the stent, obviously that would be a bigger lumen diameter, and you would be able to take the reference, relative to that area. But typically you would want to pick a location in the stent that you think is representative of what you think the lumen should be when you're selecting your bookmark. So, just to kind of review here, so where are we using AI and IVUS? So we're using it to identify the vessel and lumen borders. We're using it to identify the vessel profile, like longitudinally here, as you can see in the lower right-hand side, identifying where the minimal lumen area is. And then using the frame marker to determine not only where your minimal lumen area is, but also being able to use that to select your frame markers and then determine what your relative stenosis is within the stent after implantation as well. So just in the last couple minutes here, I wanted to mention a couple of studies that looked at comparisons between some of these technologies and IVUS experts. For this particular study, it looked at the lumen area correlation and the vessel area correlation with IVUS experts, and found that there were very high correlations approaching 0.99, 0.97 respectively, indicating that these technologies, these AI technologies, really approach that of an IVUS expert interpreting the images. This particular study looked at whether or not the AI technology versus an IVUS expert, and also compared that to a cardiologist to cardiologist. And this was kind of interesting that actually there was better correlation between an IVUS expert and the AI technology compared to two different cardiologists comparing the same images. And then lastly, in this particular study, they looked at whether or not the balloon size that was chosen and the final area measurement was similar between machine learning and human experts, and found, again, a very high correlation, particularly for the balloon selection when we integrated both the lumen and vessel diameter information. So I know, I'm sorry, I'm going a little bit long here, but just want to sort of re-review what we've reviewed, which was the guidelines for using intravascular imaging, some differences and similarities between IVUS and OCT, the pre-stent and post-stent IVUS workflow, and then examples of how we're using AI in IVUS software, much of which you may have been using already, but maybe didn't realize it was AI, and some of the additional tools that AI can provide to us, like the relative stent expansion that is probably an underutilized AI tool within our IVUS software, and then reviewed how AI compares to human interpretation. So I will stop there. Thank you.